Hello, this is Dr Clouser recording a update on our new HealthNet DART combined guidelines for management of pulmonary embolism. Pulmonary embolism, as you all know, is a very common condition that we typically will see in acute ill or critically ill patients, whether they're in the emergency department or an intensive care unit. It is something that we do see quite often, and with ease of imaging such as CT angiograms, it's quite common that these tests are obtained, and therefore we have found more and more PEs as we go looking. In contrast, just even back in the early 2000s when I was an intern, this technology didn't exist, so we really didn't scan patients for PE, and we didn't find that many because we weren't able to so easily acquire CT. But in any event, a pulmonary embolism is exactly what it sounds like. It's a clot, a blood clot within the pulmonary vasculature. And you can see this image here on the screen is an example of a PE. When we do a CT angiogram, contrast dye is injected, and what happens is the contrast goes into the right ventricle, it's pumped out through the pulmonary artery. So you see the contrast dye turns bright white, and anywhere we have lack of contrast within the pulmonary arteries and its main branches, we can note that there's actually evidence of clot. And in this image that you're seeing, you actually see an example of what we call a saddle PE or saddle embolus, because it saddles or straddles the branch of the left and right main pulmonary artery. And these are often associated with significant RV dysfunction or RV strain, and we'll get into a little bit more about that. Big point is I'm trying to give you the background that PE in our context can be broken into a few different categories. And the main category are just simple low-risk PE, which, as I already noted, can be found sometimes incidentally when we do CT scans. These are treated generally with routine anticoagulation with heparin or warfarin, and patients with small low-risk PEs generally have little to any symptoms, and oftentimes they'll even be on room air or only require a small amount of oxygen. And then there's other degrees of severity, including submassive and massive PE. We have decided as medical directors between DART and UVM HealthNet to compile a treatment guideline for acute massive PE because it is something that we see, and these are sometimes patients that you are asked to transport, and we want to give you the tools to be able to properly manage these patients. And to give you a little more physiology and background on what's going on with patients who have significant large PEs, you need to understand the effects of pulmonary embolism on the right ventricle. The first slide here, I'm just going to kind of outline some of the key points, and then I'll show you a graphic on the next slide that kind of reviews what I'm trying to say. But essentially, when you have an acute obstruction of flow out of the right ventricle, it creates increased afterload. You have increased pulmonary vascular resistance, your pulmonary arterial pressures rise, and that causes stress on the right ventricle, which over time can lead to RV failure. I think you're all aware that the right ventricle is a thin-walled structure. It does not have the ability to create a high amount of force or pressure because the pulmonary circuit is generally a low resistance circuit. So therefore, when there's an acute obstruction of flow, the RV develops stress and strain, its work goes up, and its myocardial oxygen demand increases. As the RV is unable to mount adequate pressures to pump against resistance, it starts to dilate, and with subsequent fall in RV stroke volume, the left ventricular preload falls, and therefore you have an overall drop in your cardiac output and your blood pressure starts to fall. And while that happens, that leads to decreasing coronary blood flow and therefore you develop RV ischemia, which further worsens RV dysfunction, and you kind of develop what sometimes is called an RV failure death spiral. This slide is borrowed from my friend Palmcrit, or Dr. Farkas in the MICU, and this just highlights what I've been trying to describe in the slide before. So you see increased pulmonary vascular resistance leads to RV dilation, and as that happens, you have ineffective contraction, which can lead to hypotension. Your septum can bow into the LV, which also can impair your LV filling, and again, drops your LV output and leads to hypotension. As that develops, you develop hypoperfusion and ischemia, which causes more RV dilation. And sometimes we get into the habit of thinking that giving fluids to these types of patients will be helpful, but in fact, when the RV is failing, giving additional fluid can further dilate the RV, cause the septum to bow further into the left ventricle, and further impair LV function. So paradoxically, in these cases of significant RV failure from PE, fluid loading is actually potentially harmful and should be done only under very cautious approaches. So now that you're all experts on the physiology and pathophysiology of the hemodynamic consequences of pulmonary embolism, I think we should briefly touch on general treatments for pulmonary embolism. I think it's fairly obvious that if you have a blood clot, the treatment is often anticoagulation. It's almost always anticoagulation, although I do believe there are some newer studies showing that patients with subsegmental PE without significant symptoms probably don't need any treatment at all. But in general, we treat patients with either low molecular weight heparin or enoxaparin at 1 milligram per kilo twice a day, or heparin infusion. Patients tend to do better with low molecular weight heparin. They're certainly at a therapeutic anticoagulated state faster than with the heparin bolus and drip, although there are certainly circumstances where we will pick a heparin infusion over low molecular weight heparin, especially in patients who we fear may have increased risk for bleeding. So the benefit of heparin is that we can turn it off and the heparin will be out of their system within an hour and their bleeding risk goes back down. The next category of PE, which is a large topic in and of itself, is kind of the middle category of pulmonary embolism, which we call submassive PE. We could easily do an entire hour on submassive PE because it's a large topic and there's a lot of equipoise on what is the proper treatment for submassive PE. But first of all, we have to understand the definition, and submassive PE is defined by any patient with pulmonary embolism and evidence of right ventricular strain. RV strain is described by clinical and laboratory findings, and the things we're looking for to make that diagnosis are most often bedside point of care ultrasound or formal echocardiography imaging, which we would look to see evidence of RV enlargement, or we do sometimes also look at RV enlargement on CT scan as kind of a poor man's quick and dirty echo. We also look for evidence of right ventricular myocardial injury, which would be supported by biomarker elevation or positive troponin. Brain natriuretic peptide also is less specific, but can also be noted to be elevated with evidence of RV dysfunction or strain. And then we also can look for the old school EKG changes, the classic S wave in lead 1, Q wave in lead 1, and inverted T wave in lead 3, or something simple like a new right bundle branch block. This slide is a little teaser and primer on echocardiography findings and imaging, just to give you all a small taste of the things that ICU or emergency medicine docs or cardiologists may be looking for when we're checking for evidence of RV dysfunction in a patient with an acute pulmonary embolism. For reference, on the left side of your slide, you will note what is called an apical 4-chamber view of the heart. In this view, we're holding the echo probe basically at the apex of the heart, or the point of maximal impulse. If you can imagine, just to the left of the nipple would be where we're placing the probe, and we're pointing it up into the chest, and we obtain the image on the left side, which is a normal looking heart. And I've labeled the structures, the main chambers, the LV and RV, appropriately, and the big black circles below those are the left and right atria. That white shiny structure that looks like a line in between is the interventricular septum. And if this was a moving image, you'd also be able to see mitral valves opening and closing, potentially even an aortic valve and a tricuspid valve. So what we're looking for is the comparison of the size between the LV and the RV. In a normal heart, the LV is bigger and more muscular appearing than the RV. So the chamber size, or that black area between the lateral wall and the septum, should be bigger than the RV. In comparison to the image on the right side, which is an abnormal echocardiogram, again an apical 4-chamber view, we see that the probe's in the exact same orientation for the patient as you're obtaining the image, but you can see that the right ventricle now is actually bigger than the left ventricle, which is not normal. And that can be one of your first clues that there could be a problem, although you have to take this in clinical context because there are many patients with COPD, emphysema, or other chronic lung disease which can have chronic pulmonary hypertension and a chronically dilated RV. So it's always good to know a little background on your patients and what their normal echocardiogram typically would look like. But in the context of a submassive PE, the echo image on the right side would be concerning for a dilated big RV. Rule of thumb is the RV should never be bigger than 1/3 or half the size of the diameter of the left ventricle in cross section. So as I mentioned earlier, management of submassive PE can be tricky and complex because there isn't a great deal of strong evidence to really suggest what the right treatment is, because most patients with submassive PE will do just fine on standard therapy with anticoagulation. But it does become more of a gray zone when we're talking about what we term intermediate or high-risk submassive PE, which is kind of a sub-classification in this category. And the reason it's important is because these are patients that, well, classically aren't considered massive PEs, which we will get into in a few slides. They are extremely high risk, and they have a lot of features that would indicate that they are potentially teetering on the edge of circulatory collapse. And some of the key features of high-risk submassive PEs, which in my opinion should be treated aggressively, almost like a massive PE patient. So some of those key features that I look for are things like a history of syncope, patients who remain significantly tachycardic or who just look really ill. Sometimes patients with submassive PEs will just literally tell you they feel like they're going to die, and many times they are right. These patients don't look well. They don't tolerate a lot of movement. Even just trying to sit up in bed, you'll note they'll quickly get tachypnic and tachycardic, and they just really look unstable. And then the reason that's important is because these patients actually are ones that may benefit from a more aggressive approach. And when I say more aggressive, I mean things like consideration for administration of some dose of thrombolytic. Sometimes we do a half-dose thrombolytic, or sometimes we consider them for an interventional radiology, thrombectomy, or catheter-directed thrombolysis approach. In any event, almost all of the cases that we see with high-risk submassive PEs end up in intensive care units. So if we decide for some reason not to do an aggressive therapy other than anticoagulation with heparin, we're ready to do something more aggressive if they start going south. So finally, the final category of PE is massive PE. And massive PE is broadly defined as a pulmonary embolism with evidence of hemodynamic compromise and obstructive shock. For purposes of our HealthNet PE guideline, it's defined as a systolic of less than 90 millimeters of mercury for greater than 15 minutes, or a patient who has PE requiring pressors not from another obvious cause, such as sepsis, for example. Massive PEs can progress to cardiac arrest or peri-arrest episodes, and these patients are the ones that we feel, based on guideline and a little bit of evidence, really benefit from aggressive treatment with thrombolytics. So not anticoagulation, but actual clot busting, removing the obstruction to flow from the right side of the heart as quickly as possible. And sometimes when thrombolytics don't work, we call on our friends from interventional radiology, and in rare cases have patients surgically intervened on for surgical thrombectomy. So now in the next few slides, I'm just going to review some of the treatment outlined in your new guideline and just highlight some of the new things. Number one, fluid administration. I already noted earlier in the presentation that aggressive fluid loading for pulmonary embolism patients is not recommended, although as you encounter patients, they will obviously be on different points on their Starling curves, and some may actually have a degree of hypovolemia. So the guideline does state that you can administer fluids up to a liter, but after that, if patients know better, we do recommend starting norepinephrine as your first-line vasopressor for massive PE with a goal mean arterial pressure of 65 millimeters of mercury. We then recommend adding additional pressors afterward. I would probably, if this was me in the intensive care unit, go with epinephrine as my second line, because epinephrine will have more of an inotropic effect, and we might actually need that inotropy for RV support. I would steer away from empirically starting butamine during a transport for a patient with a massive PE, because you don't have a good way of predicting how well they will tolerate the vasodilation that you see with the butamine. So in this case, treatment of shock for PE would be norepi, and then I would go with epi or vasopressin as your second and third line choices. Okay, this slide is really the crux of our new PE guideline, and that outlines how to administer TPA, which is a thrombolytic for treatment of massive PE. I will let you read the guideline in detail, but these are the key points. Number one is that TPA should really be acquired at your sending ED or medical center. We are not carrying TPA, but if you need it, you will have to acquire it prior to departure for transport. TPA should be administered under medical control, except in the instance of a cardiac arrest due to PE. There is instructions that a TPA safety checklist must be completed prior to infusion. I will go over that briefly in the next few slides. And dosing for TPA comes in two different varieties. In the setting of a hemodynamically unstable patient with obstructive shock who has a pulse and is otherwise, stabilizing under your care, we generally give a bolus of 10 milligrams IV push, and then follow that with an infusion of 90 milligrams over 2 hours. In the setting of a cardiac arrest, we're much more aggressive, and we essentially push 50 milligrams immediately and then drip 50 milligrams over 2 hours if the patient is able to be resuscitated. Okay, this slide shows you the contraindications to administration of TPA. This is well outlined in the new guideline, and you will need to review this and document that you reviewed this prior to administration of thrombolytics in this setting. And the contraindications are fairly straightforward and would seem obvious. Number one, you shouldn't give clot buster medication to someone who's actively hemorrhaging. Number two, patients with history of recent ischemic strokes have a high risk for hemorrhagic conversion, so they're typically contraindicated for TPA administration. Patients who've had recent neurosurgery or head trauma are often excluded, We do run into this from time to time where a patient has a submassive PE and syncopizes and whacks their head on a table, and then we really wring our hands wondering what to do, if we should give thrombolytics or not. Typically, we do not do that, even if we're doing what's considered a, quote, safe dose, which would be 50 milligrams of TPA over 2 hours. We would probably go with a more interventional approach in those cases. Further contraindications include history of brain tumor, AVM, or cerebral artery aneurysm, and obvious GI bleeding or bloody diarrhea, although I think these are more of relative contraindications because GI bleeding can be corrected with intervention. And then lastly on the checklist is severe uncontrolled hypertension. Just like an ischemic stroke patient who gets thrombolytics, if they're very hypertensive prior to administration or during administration, their risk for intracerebral hemorrhage is higher, and therefore you're putting your patient at risk to have a complication from the treatment that you're giving. This slide outlines your new guideline considerations to not give TPA, and these are all relative again, and that is number one, age over 75. We do know that the older you are, the higher your risk for intracerebral hemorrhage with TPA administration. Pregnancy is another one. Arterial puncture at a non-compressible site could create issues. Major recent surgery within 3 months. I think this again depends on what kind of surgery we're talking about. I think the risk is lower when you're talking about a laparoscopic appendectomy versus AAA repair, for example. And then another relative contraindication or consideration to not give TPA is in a patient who's had a prolonged period of CPR because of the risk of hemothorax and other hematoma or bleeding spots or liver lax with hemorrhage or splenic lax, etc. Lastly, our document outlines things that need to be documented and monitored after or during administration of TPA. Essentially, what you're doing is watching very closely for evidence of acute hemorrhage, or our biggest fear is development of an acute spontaneous intracerebral hemorrhage, which is why we recommend that you need to perform and document neurological checks every 15 minutes, BP every 15 minutes. You have to watch for sites of bleeding. Note that these patients will often ooze from IV puncture sites. If they have an NG tube, they can get nosebleeds. So anywhere there's been any disruption in their skin, you could see some oozing or bleeding. And then, in relation to the neurological status, you're going to be looking for acute changes in mental status, complaints of headache, nausea, which could be, a warning sign that the patient's bleeding and developing raised intracranial pressure. And then due to administration of the TPA, you can very rarely see evidence of angio or laryngoedema of the mouth and tongue. Okay, that concludes our brief overview of pulmonary embolism and our new HealthNet DART combined PE treatment guideline. Please reach out to me or Dr. George if you have questions, because we're certainly happy to talk over this because this is a new thing. I want you all to feel comfortable and well versed in these new treatments, therapies, and clinical scenarios. So thank you for listening and paying attention. I hope you found this helpful and educational. Bye.